Hello, everyone, and welcome to the live lecture for HIT205, which is our introduction to ICD-10 CM coding. We are in week number 5. I want to remind everyone that the live lecture is not a tutoring session, and that if you have questions during the week relative to your chapter reading, your chapter exercises, that it is very important that you reach out to your instructors for assistance. I have spoken with via email most of the instructors for this course, and they have indicated that throughout the week they don't hear from you. I occasionally hear. I think I've gotten 2 phone calls this term, and when I do get an email, it'll be relative to a code for the round table. And really, the objective of the round table is for you to put your skills into use, and to go with your gut and think what the correct answer should be. Because keep in mind, for the coding round table, you're being graded on your participation, with your first post being completely submitted by Wednesday, 1 post with both cases, and then your 2 follow-up posts based on the instructions that are listed under assignments. So whether or not you get a correct answer in the round table will really not impact your grade. Our goal for the round table is for you to understand the process. Also understand that you are coding 14 records over a 7-week period. You really are just trying to understand from a basic perspective the process. Inpatient coders are coding about 3 records an hour. And at 3 records an hour, we know that you're not going to be able to master the process. We know that because it's impossible. 3 records an hour from an inpatient coder, that's 24 records a day. So you guys are really at this point in the learning stages of just the system, in addition to the guidelines, and adding that together with abstracting and coding inpatient records. So don't beat yourself up if you don't get all the answers right. I see some people who are like stressing out because the relative weight is wrong. Really focus on capturing the correct codes. Focus on learning the guidelines. And then if during your career you're working you get an opportunity to work as an inpatient coder, you will have your facility policies in place, because you hear me say often that what we're coding in the round table, or the answers that we present to you, are the floor of what can be coded, not the ceiling. Because some institutions have policies where they want you to capture each and everything that you see in the record. And some other organizations say, we want you to code that principal diagnoses, and if there were any secondary diagnoses that were treated, we want you to code those. But we don't want you to spend time picking up a history of a splenectomy, a history of this, when in fact it does not impact the treatment that's being received today. So you have to consider that, but also consider, until you are sitting in the workplace setting coding 5 days a week with someone that's giving you feedback on every record that you code, you're not going to master the process. And I'm not saying that in a negative manner. I just want everyone to be realistic. Also, on the exams that you're going to take, the RHIT, the CCA, there will not be any medical records on that exam. There will be very, very, very small 1 to 5 sentence scenarios that will be very basic. And you know what they really want to know? What you're really being tested on? Do you know how to assign a code? And do you know the guidelines? Those are the 2 things that they expect. Because The RHIT exam and the CCA exam is not about work experience. It's about the theory and your ability to apply what you're learning from a theoretical perspective in the classroom setting. So those exercises that we did last week, those are perfect examples of what you can expect to see on these exams. You will find that some people will have short questions, some people will have longer questions, but they will not, on the RHIT exam and the CCA exam, it will not be a 30-page typed or handwritten record. That is not the objective of that exam. And even on the more advanced coding exams, the CCS and the CCSP, you will have medical records, but they won't be 30 and 40 pages. They won't be handwritten. When the coding exam, CCA, CCSP, first came out, the exams were like handwritten. But today in 2016, everything on the exam is typed. Okay. And so, but again, for our purposes here, learn how to assign the codes based on coding guidelines, and then understand how we abstract and code inpatient records. All right, so let's talk about this week. This week we are climbing, every week we're like climbing down the tabular list of the coding manual. And as you may recall me saying last week, guidelines are very, 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 very important. And each week we're covering about 3 to 4 chapters of guidelines. Last week, or the week that's ending today, we did the respiratory system, we did the cardiovascular system, we did the digestive system, and the skin. And so when I say that you're not going to master it, think about it from this perspective. And again, I'm not trying to be negative. I just want you to understand that this course is an introductory course. So for example, we spend the 7 days on those 4 chapters, and then essentially we move on to the next set of chapters. So you can see where if we spent 3 or 4 weeks on a chapter in the coding manual, then yes, maybe you would learn more. But again, this is an introduction. This is not an intermediate class. This is not an advanced class. It's an introduction to the coding system. So focus on learning guidelines. Speaking of guidelines, I mentioned this previously, but I want to mention it again. In your tabular listing at the very beginning, you'll notice that the guidelines are listed there for that chapter, as well as some examples. So let me just make sure everyone's clear. In the front of your coding manual, yes, there are the guidelines. They are about 30 pages in length. Several of you have heard me mention that I have a physical copy of the guidelines, which is about 115 pages in length. And the reason that I have the 115 page packet is so that A, the font is larger, but B, I can highlight things, make notes in the margin, where it's a little difficult to do that in the textbook. Now then also I want to mention again, in the very front of each chapter in the tabular list, in the front of each and every chapter in your tabular list, not only will you see guidelines, but you will also see examples. And what I like about those examples is that they take the guidelines and give you an example scenario with codes. And for me, that's like, oh, it helps me understand how to apply certain guidelines. So I just think it's very valuable to take a look at those examples. Yes, there are some examples in the book. And again, the book, what's the name of the book? Our textbook. Basic, let's see, where's mine? Basic ICD-10, CM, PCS coding. So it's all about the basics, because before you can do advanced coding, you got to learn the basics. Very, very important. So diseases of the musculoskeletal system. One thing I want to let you know about this particular chapter, and I'm going to mention this again when we get to the coding roundtable, is that in our coding system, we have the diseases of the musculoskeletal system. Those codes start with the letter M, and it's chapter 13. But then we have codes in chapter 19, which are for injury, poisoning, and other certain consequences of external causes, and those codes start with a letter S and a letter T. What I want to point out right now, and I'm going to remind you of this later, is that in the letter S, which is not our chapter for this week, those codes have injuries, fractures that are traumatic in nature. Whereas in our chapter for the week, musculoskeletal, those codes are for conditions that are related to a previous injury, or recurrent conditions, or conditions that are related to a disease process, such as patients that have osteoporosis will often have weakened bones as a result of that condition. So I want you to remember that. I'm going to remind you later when we get to the round table, and you'll see why. Okay, so let's talk about some of the guidelines that we have here. A lot of the codes you're going to see are going to identify left and right. So not only left and right, and unspecified. And someone asked me before, why would they have unspecified codes for a body part where there's a left and right? Well, I can give you an example. Let's say a patient had an injury and they were seen in the emergency room, and they were told to follow up with the doctor. And they get to the doctor and they tell the doctor, oh, I was seen in the emergency room for a problem with my leg, and it's all better now. And then the doctor says, well, which leg is it? Oh, I don't know. I don't remember. Right? Well, they don't remember, so the doctor can't use left or right. Another example that I've seen, patient goes to the emergency room, they have an ear infection, and they get some antibiotics. They're told to follow up with their doctor. They follow up, and the doctor says, okay, I looked in your ears. Both of them are clear. Well, obviously, because they had antibiotics, right? And then the doctor says, well, which ear was the ear infection in? The patient says, I don't know. So, yes, while you're thinking, how can we have left and right ear, unspecified ear, left and right leg, unspecified leg? Because there could be situations where the provider truly does not know. However, and I do lots of education sessions with doctors. I'll quite frequently go to the hospitals in the area 7 a.m. in the morning and do an hour education session with the providers. And one of the things I'll say to them is, doctor, you have to paint that picture. Doctor, you have to tell us if it's left or right. Doctor, you have to tell us if it's acute or if it's chronic. Doctor, you got to tell us if it's the bone versus the joint. And when I say that to them, they don't realize that the codes are that specific. Because you got to remember, doctors don't learn coding. Doctors learn how to treat patients. They don't know about ICD-10 CM and ICD-10 PCS. And if they do, it's at a very superficial level. They don't have a class where they have these 115-page guidelines and these big fat coding manuals and all of that. They learn how to treat their patients. So let's talk about a couple of guidelines here. I already talked about the concept of left and right. Um, there is a guideline that states that if the patient's condition is on the left and the right side, and there's a bilateral code available, you use the bilateral code. In absence of that bilateral code, you're going to use a code for the left and a code for the right. You can't use one code and say times two. I've seen where some people will put a code number down and they'll put a L behind it to mean that it's left. Diagnosis codes don't receive any modifiers on them to indicate left and right. Let's see. Acute traumatic versus chronic or recurrent musculoskeletal conditions. This is what I mentioned earlier in the chapter that we're in today with the letter M. These are for chronic or recurrent musculoskeletal conditions, your pathologic fractures, etc. Whereas in chapter 19, which is not our chapter for this week, those are for traumatic injuries. So if you happen to be coding a scenario this week and it's an injury on the quiz, please know that your main term, yes, will be fracture, but under fracture, you want to go down to where it says pathologic as opposed to traumatic, because pathologic will get you into the M codes. The traumatic will get you into the codes that start with the letter S. Okay, coding of pathological fractures. Something that we're going to see here that I want to just remind you of, and some folks appear to still be having a problem with this, and I actually meant to do some investigation to see if those individuals that continue to have this problem are listening to the live lectures, because instructors, we can see who's actually listening to the live lectures. Even if you don't attend live, we can see that you're actually listening. But some people are still confused about the use of that seventh character. So, for example, the guidelines talk about under coding of pathological fractures, they talk about the seventh character A is for use as long as the patient is receiving active treatment. They give examples of active treatment. The seventh character D is for encounters after the patient has completed active treatment. And then they talk about care for complications of surgical treatment. But let's just focus on the A and the D right now. The A and the D represents a seventh character, and it has to go in the seventh position. So what that means is it can't be in the sixth position, it can't be in the fifth position. If the guidelines are stating that that code, that character, I should say, has to go in the seventh position. For example, codes in category M80, it tells us that we need a seventh character. Okay, so once you verify your code, and let's say it's M80 point M80.011 is what you see, and it tells you that it needs a seventh character. Your code is not complete unless you have that seventh character on the end. What I am seeing when I'm grading quizzes is that code without the seventh character. The other thing that we talked about several times is a situation where you're in the tabular list and you got code W19, for example, and it tells you that a seventh character is needed, and you don't have 6 characters in front of you. We learned during, I don't know, week 1 or 2, that we have to use the placeholder character. So I'm not sure if the people who are saying that they don't understand this concept are actually have listened to the live lectures, but I want to make sure everyone is clear that when it tells you that a seventh character is needed, that character must go in the seventh position. And if you do not have 6 characters that precede that seventh character, we have to use the concept of the placeholder X. Oh, and I just noticed I put too many X's in. Let me erase that. So it should be 1, 2, 3, and then an A. All right, that just proves I can't talk and type at the same time. Okay, so let's see, osteoporosis. For osteoporosis, we really have two main categories of codes. We have M81, which is osteoporosis without a current pathological fracture. And then we also have category M80, osteoporosis with a with a pathological fracture. So M81, osteo without a pathological fracture. M80, osteo with a current pathological fracture. Again, I want to emphasize that over here, we're not talking about traumatic fractures. We're talking about pathological fractures. Patients that have pathological fractures are the result of a disease process. That disease process has caused their bones to be weakened, which makes them more prone to fractures. All right, so that was all for the musculoskeletal system. On to the nervous system. They start with the letter N. Oh, something else I want to mention that I noticed on the quiz, that some people are adding codes that have nothing to do with the content for the week. Just remember, each week in the quizzes, your quizzes are based on the chapters that we're covering. So this week we're covering, I talked about the letter M, and then now I'm about to talk about the letter O. So your codes are in the quiz are related to the content for the week. All right, so letter N, the genitourinary system. When I first learned ICD-10, I was trying to figure out ways to remember these letters. Like, what if I can't find the code? If I could at least know what the first letter is, I can go over there and look for it. So M, muscles, musculoskeletal. N, okay, this is what I said. N, nephro. Nephro means kidney, right? So genitourinary system. Okay, so couple of guidelines here. First one related to chronic kidney diseases and the stages. The stages are designated as 1 through 5, and the codes actually kind of correspond to the stages. So like the code category is N18. So N18.1 is stage 1, N18.2 is stage 2. Then we have N18.6, which is when the provider says the patient has end-stage renal disease. There's also a guideline that states if the patient has chronic kidney disease and a stage is listed, and they also list end-stage renal disease, we're only going to list the code for end-stage renal disease first, only. So you're probably wondering, well, why do we do that? I want you to remember that coding this system is a classification system. How we classify diseases based on guidelines, not how doctors classify diseases, how we classify them. So let me just repeat that. Guideline states, if the doctor lists a stage of CKD and ESRD, guidelines state we only are doing the code for the ESRD, which is N18.6. Let's see what else. Chronic kidney disease and kidney transplant status. There is a Z94 code, Z94.0, that shows that the patient has previously had a kidney transplant. It shows the status. Previously, I gave a list of main terms that lead to the different Z codes. That list that I gave you, I encourage you to add terms to it when you discover additional ways to locate the Z codes. I would definitely look them up. Okay, chronic kidney disease with other conditions. There's a guideline here that states that Patients with CKD often have other conditions, most commonly hypertension. We talked about hypertension last week, as well as diabetes mellitus. And according to the guidelines, how we sequence those codes, 'cause that's always a question a lot of you ask. Well, which one goes first? Well, which one goes first is based on guidelines. And in the absence of a guideline, you can sequence them any order you want to. You'll probably notice that when we post the answers for the coding roundtable, that we generally have our Z codes last. So if it's a situation where it's like last week was absence or something, history of urinary tract infections, and allergy to a medication, we listed those last because those particular Z codes are not going to impact reimbursement, so we listed those last, which is different than like a few weeks ago when we talked about neoplasms. And we have a situation where the patient is specifically there for the therapy, the chemotherapy, the radiation therapy, the immunotherapy. Those Z codes actually go first. So a Z code that says a patient has, is allergic to penicillin, that code is not going to impact our reimbursement. So that's not one of the codes we will be listing first. So it's just about, in terms of sequencing them, is there a guideline that says we must sequence them in a certain order? If there is, we follow that guideline. If not, all bets are off. But I will tell you that typically with those Z codes, the ones that just show a status, we are typically not listing those in the first position. Okay, so that's all for the genital urinary system. Oh, now our big doozy for the week. And I first want to grabbing my coding manual, because before we start to talk about this chapter, I think it's important to look at the tabular listing. Number one, these codes, they start with a letter O. When I first learned them, I said, oh, baby, the baby's coming. So these codes are for the mommy. These codes are not for the baby. So this is for the pregnancy, the childbirth, and then the state of the mother after childbirth. These codes are not for baby. These codes are only for the mommy's chart. All right, so I mentioned earlier, and I'm going to say this again, at the beginning of each and every chapter, they have the guidelines, and then they have an example. So, for example, the first guideline they talk about are general rules for obstetric cases. And then the first guideline is codes from chapter 15 and sequencing priority. They give you the guideline, but then in the purple box, they give you the sequencing of a scenario. So a patient has a bladder abscess. They are at 25 weeks gestation. And then they give you the code. So 023.12 shows infections of bladder in pregnancy, and it shows the second trimester. That's something important to note. For pregnancy codes, we have to show what trimester the patient is in. So the patient is 25 weeks, that's the second trimester. Then you'll notice that they have a secondary code of N30.80, other cystitis with hematuria. Now you're like wondering, well, why do we need that second code, other cystitis without the blood in the urine, when we already know that they have an infection of the bladder? Well, that's just it. We know that they have an infection of the bladder in pregnancy, but we don't know what that actual condition is. So in addition to saying, hey, the patient is pregnant, they're in their second trimester, they have an infection of the bladder, that second code shows what the actual infection is. In our case, it's the bladder abscess, which codes out to N30.80. Then you'll notice that there's a third code that says 25 weeks of gestation, Z3A25. This is a secondary code that goes on the patient's records during the pregnancy part. So I want you to notice, not for delivery, but just during the pregnancy part, during those 40 weeks of pregnancy. So they have a second scenario where the patient is pregnant at 21 weeks gestation, admitted with excessive vomiting. So they give you a code O21.2, late vomiting of pregnancy, and then Z3A.21, because the patient is 21 weeks gestation. So 2 points I want to point out here. Most, not all of our codes in this section will show what trimester the patient is in, first, second, or third. On top of that, when they're pregnant, not during the delivery, when they're pregnant, we always have to show exactly how many weeks of gestation the patient is in. And you should notice a theme. In that first scenario, Z3A.25, 25 weeks gestation. This scenario, Z3A.21, 21 weeks of gestation. Let's look at another scenario. Again, I am in chapter 15 of the tabular list, and what I'm trying to illustrate here are how important it is for you to look at these guidelines in the front of each and every tabular list and look at the examples, because they give you some really good examples. So let's see. This next patient admitted at 27 and 6/7 weeks gestation for hemorrhaging from the placenta previa. 3 days after admission at 28 and 1/7 weeks gestation, she developed gestational hypertension. Now, this particular scenario happens to be under the guideline that is relative to selection of trimester for inpatient admissions that encompass more than one trimester. And the reason I'm pointing this out is because you'll notice patient was admitted at 27 and 6/7 weeks gestation. And then after admission, 3 days later, they were at 28 and 1/7 weeks gestation. So the question that you should be asking yourself is, well, which one do I go with? Are they, in the second trimester, or are they in the third trimester? Well, let's see what the guidelines state. In instances when a patient is admitted to a hospital for complications of pregnancy during one trimester and remains in the hospital in a subsequent trimester, the trimester character for the antepartum complication code should be assigned on the basis of the trimester when the complication developed, not the trimester of the discharge. They go on to further say, if the condition developed prior to the current admission or encounter, or represents a pre-existing condition, the trimester character for the trimester at the time of admission should be assigned. Okay, well then look what they do. This example, the first code, the placenta previa with hemorrhage, second trimester. That's what she was admitted with. But this gestational hypertension, they have it listed as third trimester. Why? In the scenario, 3 days after admission at 28 and 1/7 weeks gestation, she developed gestational hypertension. The guidelines state the trimester character for the antepartum complication code should be assigned on the basis of the trimester when the complication developed. So here you're like, wow, one code says second trimester, one code says third trimester. Again, it's related to the guidelines. And this is why I keep saying to you guys over and over and over again that you have to follow the guidelines. So let's look at that again. The trimester character for the antepartum complication should be assigned on the basis of the trimester when the complication developed. The trimester character for the antepartum complication code should be assigned on the basis of the trimester when the complication developed. When the complication developed. When the complication developed. When you're at home and you're reading these guidelines, you have to say them to yourself over and over again. When the complication developed, not the trimester at discharge. So then, this is why I like these scenarios, because they just flat out say, okay, patient admitted, 27 to 6 weeks gestation for hemorrhaging from the placenta previa. 3 days after admission, now they're at 28 and 1/7 weeks gestation, she developed gestational hypertension. The trimester character for the antepartum complication code should be assigned on the basis of the trimester when the complication developed. So this is what you have to do at home for those guidelines to sync. It's not the trimester at discharge. It's when the complication developed. And then the last thing I want you to see in this little box is she's 27 weeks pregnant. And what's that code? Z3A27. Okay, the other guideline I want to show you, and I absolutely love these examples because it's one thing to see the guidelines and learn them, but it's another to see an example. So the next one, the 7th character for fetus identification. When a patient is delivering, the 7th character is used in certain categories to show which fetus had a complication. So why do we need that? Well, think about it. When I first learned about these codes, I said, oh, Octomom. Octomom had a bunch of babies, didn't she? So surely one of those babies had some type of complication, right? Well, in ICD-9, we couldn't show which fetus actually had a complication. Well, in ICD-10, we actually can show that. So it's so awesome that these codes can show that. But anyway, so if it's a single gestation, we just assign a character of 0. If the doctor doesn't know, sorry about that. My screen, guess because I didn't touch the screen, my screen went out. So single gestations is 0. When the documentation is insufficient, it's a 0. If the doctor doesn't know, because sometimes the doctor doesn't know, it's a 0. But then if it's affecting other fetuses, like fetus number 2, then we have a 7th character for that. Let's look at the example. Maternal patient with twin gestation is seen after the ultrasound identifies fetus B to be in breech presentation. So here you'll notice that the final character of a 2 shows that it's fetus number 2. Also want to mention, if you notice here, that Z3A code is not listed because remember it's only for during the pregnancy, not for the what do I want to say? Not for the episode or the delivery time frame. Okay, couple of things I want to show you. Let's go in the alphabetical index and go to the main term of pregnancy. And those of you who are in the medical billing and coding program, you really should be getting into your book, because these are the same books that you're going to take with you into your testing center. So the same books that you're going to take in with you to your testing center, you should become friends with them. You should make notes, because guess what? That'll be the same manual that you'll take in the exam with you. So I just think it's awesome that you get to take the same manual that you're using in class into the testing center with you, because you are like friends, right? You're like best friends, as opposed to them giving you a manual that you don't know how to use, that you haven't spent time with. Okay, a couple of things I want to show you under the main term pregnancy. Okay, number one, under the main term pregnancy, there's lots of subterms and the subterms to the subterms. If I were you, I would go in my book and I would identify these major subterm areas. I'm going to show you some examples. So under the main term of pregnancy, the first subterm that has a lot of subterms under it is the subterm of complicated by. So main term pregnancy, complicated by. Under complicated by, the first option that you have is abnormal or abnormality. And then that list kind of goes on for a couple of pages. And in my book, and let's see, which one do I have with me today? I have the ICD-10 CM Expert for Hospitals. In my book, complicated by doesn't end until like page 254, when the word examination. So it would be main term pregnancy and then examination. And then underneath there, you got some more words, extrauterine, fallopian, false, hidden, high risk, incidental, finding, interstitial. It goes on. And then the next word I see that has a couple of subterms underneath is the word molar. So what I'm trying to get you to see, I'm not finished yet, but what I'm trying to get you to see is just spend some time looking at the index. A lot of people say, oh, I can't find this code. Well, how much time did you actually spend looking at the index and looking at the subterm? So under main term pregnancy, you got pregnancy complicated by, and it's got a whole, in my book, that starts on page 251, and it's all on page 252. And how do I know that? At the very top of each page, it says complicated by, continue, complicated by, continue, complicated by, continue. Then I'm in page 253. At the top, says the same thing. I'm in an alphabetical index. Pregnancy, complicated by, pregnancy, complicated by, pregnancy, complicated by. I go over to page 254, and in the top says it again, pregnancy complicated by. And then when I look at the second column on page 254, it says pregnancy molar. So then I know that the complicated by has ended. So I look on the bottom of page 254, I see my molar that goes to the middle, top or the upper half of page 254. Then it goes into multiple and mural, normal pregnancy. Oh, you should highlight those codes where it says normal, supervision of, because that's like the patient that's coming in for the office visit for their pregnancy. You know how you come in for your regular visits. That might be a question that you'll see on the quiz. And then, of course, remember I said earlier, when they are pregnant, we always want to list our weeks of gestation. So 2 things I want to show you on page 254. 3 things. The word normal, I would put a box around that. That's for your office visits. Then they got a area for supervision of, and they got different options. And then look, weeks of gestation. Now, I think the weeks of gestation is like, got to be like the coolest thing in the world to a code to remember, because if the patient is 8 weeks all the way to 42 weeks, the code is Z3A and whatever the weeks are. So if they're 15 weeks, Z3A 15. If they are 38 weeks, Z3A 38. On the quizzes for week 5, and I do these live lectures every 8 weeks unless it's the term that I'm not teaching. Then it probably is a recording that's playing. But I do these live lectures every 8 weeks. I can always tell when people aren't listening to the live lectures, specifically when this week comes, because you will have several scenarios on the quiz where the patient is pregnant, and it'll say like 30 weeks, 32 weeks, 12 weeks, whatever the case may be. And I can always tell who hasn't listened because they don't have these secondary codes, Z3A, etc., etc. The other thing I want to point out for you is you may notice under the main term pregnancy, under pregnancy, where it says weeks of gestation, behind each and every code, it has the word following Z36, following Z36. Well, like, what does that mean? This is what that means. You can find code Z3A.08 after code Z36. Now, just because I'm visual, you're visual, let's go over the code Z36 in the tabular listing. So Z36 in the tabular listing. And again, I have the hospital. I actually have both of the books. They both have the same codes in them. But once you locate code Z36 in the tabular list, you will notice that codes Z36, or that one code Z36, after it, you have all those Z3A codes. The reason that they put this note here, this note was not here when I first started learning ICD-10. They put the note here because in your brain, in my brain, you're like, okay, we should have Z36, and then Z37, and then Z38, and Z39. Nothing in my brain tells me in order to find Z3A, I need to go behind Z36. So they put that note there just to let you know, hey, if you're trying to find Z36 or Z3A in the tabular list, it is following Z36. That makes sense, Jennifer? Yeah, and so while we're looking, let me show you another example. I don't think I show you this, and I have so much to show you each and every week. It's like one of the students that was listening to one of the lectures I used to have as a student at the Chicago campus when we were on campus, and she said, in your live lectures, I feel like we're in class again. So we used to have class for 3 hours. So, and I'm trying to squish all of this into 2 hours. But anyway, let me just show you this real quick because I got to show you while it's on my mind. So, let's see. I think the word, let me find it first. It's related to carcinoma. Is what I want to show you. And if you go to the main term of carcinoma in your alphabetical index, so main term carcinoma, subterm Merkel cell, main term carcinoma, subterm Merkel cell, and Merkel is Merkel, Merkel cell. If you look here, it says Merkel cell C4A9 is following C43. Anal margin C4A.51 following C43. So same concept there. In order to find that code, you got to go and look for C43 first. That note, again, was not present when I first learned ICD-10 coding. And we were like, where in the heck is this code? And then the people who published the code book the following year added that note in there. And we're like, thank you very much, because we could not find that code. Okay, so let me just make sure everybody understands a couple of things here. Number one, these codes are for mommy. Mommy, mommy, mommy. All right? They are used for the stages of her pregnancy, the childbirth, and then after, which is called the preperium. The other thing I wanted to mention is we talked about that a lot of these codes show the trimester. Okay. We also talked about the Z3A, which is a secondary code that shows the weeks of gestation. We also talked about the 7th character that shows the fetus identification when there's a complication. That's during delivery. We also talked about when the patient has a condition during an inpatient stay where we want to assign the code on the basis of the trimester when the complication developed, as opposed to the trimester at discharge. So should be assigned on the basis of the trimester when the complication developed, not the trimester at discharge. Okay, now again, we only have a short amount of time, so I cannot go through each and every guideline, but there's a couple more I want to show you. Routine outpatient prenatal visits. Those are codes Z34. I actually just showed you how to find them. Main term pregnancy, subterm normal. You'll notice Z34 is not in chapter 15. And according to the guidelines, if you're using a Z34 code that says a routine outpatient visit or routine prenatal visit, you can't use any of these codes that start with an O. So if you're going to say routine outpatient prenatal visit, you're going to have Z34 category code. That's not the full code, but once you verify it in the tabular list, you'll see what the full code should be. And then the other thing that you got to list, remember that code we talked about a few seconds ago? Z3A. So let's say that a patient is coming in for their prenatal visit. They're 30 weeks pregnant. You know right off the bat, they have no complications. You're going to have Z3A.30 as a secondary code. The Z3A code is always secondary. It should not be used alone. Okay. But your first code is going to say Z34, for example, 00. Routine outpatient visit, first pregnancy, normal, no problems, etc. Okay. Let's see what else I wanted to show you. The last thing. Outcome of delivery. All right, so outcome of delivery. The patient has a baby today, and it was a single live born infant. There is a secondary code that is used to show if it was one baby, if it was two babies, and that's code Z37 category. That's for the outcome of delivery. And I made one mistake that I just told you guys I need to correct. On the day of delivery, we do identify the Z3A code for the weeks of gestation. That was a mistake. So on the day of delivery, so pregnancy, childbirth, and delivery, we do use Z3A to show how many weeks the patient is. So if a patient is delivering today, you're going to have two Z codes. One to show the weeks of gestation, and then two to show the outcome of delivery. So on the day of delivery, two Z codes, Z3A and the weeks of gestation, and Z37 to show how many babies the person had. Okay, again, I cannot go through all of these guidelines. I will provide you guys with a copy of the slides, but there are pages and pages upon guidelines related to someone that's pregnant. Oh, I do want to show this one. If I only had more time. Normal delivery, code O80 for normal delivery. So this particular code is used when the delivery is normal as defined by the coding manual. And the coding manual states we can use code O80 when full-term delivery, single delivery. So if they have twins, not a normal delivery. So full-term, single infant, and basically they just push that baby on out. So the only other code that can be listed with O80 are those Z3A codes. Z3A, Z37. That's the only thing. You can't say that it was breech and it was normal. You can't say it was twins and it was normal. It has to be full term. It has to be single, and any antepartum conditions that they've had, they've been resolved. They don't have any complications during delivery. It has to be literally one baby, full term, push that baby out. And then, of course, we're going to list the outcome of delivery. Okay. And more guidelines, more guidelines. So many guidelines to read. Again, I cannot cover them in this particular platform here. All right, the last chapter for today. So let's look. We got M for musculoskeletal, N for the genital urinary. We have O baby, the codes for the mommy. And then lastly, we have codes for conditions that are originating in the perinatal period. Now, remember I said that the letter O codes don't go on the baby's record? Well, the baby has their own codes, and those codes are for the letter P. So these codes are only for the newborn records. They do not go on the mother's records. Okay, so let's look at a few guidelines here. Principal diagnoses on the birth record. So remember I said those codes that start with a letter O, it's like, oh baby, the baby is coming, right? Well, on the mommy's record, and on the mommy's record, remember we have that outcome of delivery code Z37 something, right? Well, on the baby's record, quite naturally, the first code is like, hi, I'm here, right? Because the baby doesn't give birth, the baby is born. So on the baby's record, The principal diagnosis is from category Z38, which is live-born infants, which are divided based upon the place of birth and the type of delivery. And you're like, place of birth? Well, you know, some babies can't wait to come out, so they're born in the cab or they're born in the ambulance. So the Z38 codes say, I'm here world, and they show where they were born, as well as, was it a C-section, was it a vaginal delivery, etc. Now, the baby is only born once, so those codes are only listed once. And what do I mean by that? Well, sometimes babies are born at one hospital, and because of a condition or conditions have to be transferred to another hospital. And so that receiving hospital, they can't get a code that says, hi, I'm here. That's only for the hospital where the baby was born at. So that second hospital, they have to have a code that shows why they're at this other hospital. So maybe they're born at one of those small hospitals, and that small hospital cannot take care of that baby's condition, and so the baby has to be transferred. So hospital A, they get to report the hi, I'm here code, and then hospital B gets to report the code that shows why that patient was transferred to them and what condition that they are going to be treating. Let's see. Other than that, I think these guidelines are pretty straightforward. They truly are. So I will not cover them. I'm going to get to the round table, and we are going to be out the door for today, so everybody can enjoy their time with their family. Okay, so this week codes are M, N, O, and P. For the mommy's chart, we have those Z codes that we could potentially use, Z3A, Z37, and then for the baby's chart, the first listed code is that Z38 code, the hi, I'm here code. All right, so for the round table for this week, you have two charts, case 17 and case number 19. So let's talk about case number 17 first. But before I do that, I want to remind you, I had to type this out because I keep saying it and I don't think some people are listening, so I wanted to type it out. The codes that you are going to see posted by your instructors each week represent the floor of what can be coded, not the ceiling. And what I mean by that is when you go and work at an organization, they may have certain things that they want you to pick up and code. And in this setting, we are just picking up at a minimal what should be coded, okay? Even though I'm giving you these tips, it's still your responsibility to review the entire record. Yes, I know some are handwritten, some are typewritten. It is still your responsibility. It is also your responsibility to utilize coding resources. I don't know if you guys have noticed, but I have been emphasizing over and over again the guidelines, emphasizing over and over again coding clinic. And I noticed in my discussion board last week that I still had some people, when I asked about coding clinic, they went and just Googled something on the internet. The reason why I'm asking you about coding clinic and exposing you to coding clinic is that on national exams, they may ask you a question related to coding clinic, not like an article. Nobody expects you to memorize all those coding clinic articles, but the expectation is that you know what coding clinic is and that you know how to use it. And if you just go online and Google some article, that's not coding clinic. Coding clinic is the reference that is published by the American Hospital Association, and it has articles related to ICD-10-CM and ICD-10-PCS. So if you haven't had a chance, definitely go and look up coding clinic articles inside of 3M. Okay, let's see what else. And then, of course, the guidelines. Guidelines. Okay, case number 17. Now, remember earlier today, I mentioned that this week, the fractures that we're coding are related to the musculoskeletal system, and they start with a letter M. Okay, well, apparently, when this class was created, we were unable to find a medical record that has a principal diagnosis of a musculoskeletal condition. So for this case that you have, case number 17, your principal diagnoses and actually your admitting diagnoses, they're exactly the same, represent a fracture but not a pathological fracture. So in fact, your patient has a partial tear of a medial collateral ligament on the left. That is a traumatic injury, traumatic fracture, not a musculoskeletal condition that's chronic, recurrent, or due to a disease process. So just know, for this case, it is a traumatic injury code, so it's going to start with a letter S. Let's see what else I can tell you. This patient is receiving active treatment for this condition, so your seventh character is going to be with the letter A. Let's see what else I want to tell you. Oh, this patient was at work when a tree snapped back and struck him from the lateral aspect of the knee. We have not really talked about these codes, but I want to talk about them now. We have codes that identify the external cause of an injury. So if you pull out your coding manual, go over to the index to external causes. Again, I always know who listens to the live lecture because I'm going to show you how to find the code for this case. And those people that haven't listened to the live lecture, they won't have this code. Well, they may get lucky. The index to external causes is directly behind the table of drugs and chemicals. Okay. And the index to external causes, it can really show 5 things. It can show the place of occurrence. That's what these codes can show. They can show the activity that the patient was doing. It can show external cause status, such as military, non-military. It can show whether this situation was on purpose. You know how sometimes people, intentionally want to hurt somebody. Like here in Chicago, people intentionally are killing people, which is absolutely crazy. I know it's happening everywhere, but it's happening a lot in Chicago. So these codes show, let's see, what did I tell you? They show you how, it's like the cause. They show you the intent, was it intentional or unintentional? They show you the place of occurrence. They show you the patient's activity. And then they also show you the external cause. So the external cause codes, they have their own index. They show 5 things. So how it happened, we know our patient, or you will know, our patient was struck by a tree. It can show the intent. It can show the place where it occurred. It can show the activity, and it can also show the external cause status. So in the index, we're looking at the external causes index, and we know that our patient, poor thing, had a little situation at work where, what did I say? The tree snapped back and struck him from the lateral aspect of the knee. So, in the alphabetical index, there's a couple of ways you can locate this code, but let's try by looking at the main term, struck, S-T-R-U-C-K, and see if we can find it there. So let's see. Struck. Let's see what our options are. Airbag, alligator, animal. These codes are actually quite comical, and even though I say it's comical, you know it's true, right? Because if you watch TV, you'll see that people can have accidents with alligators and lions and tigers and bears. Oh my. Okay, so let's see. Avalanche, ball, bat, a bullet, crocodile, a dog, a flare, a hailstone, hockey, landslide, law enforcement, lightning, machine. It just goes on and on. Let's see. Object, jet skis, surfboards, windsurfers, earthquakes, caves. Object, in sports, thrown, in sports, other person. Police, sports equipment. So, do we see anything here? We see a lot of stuff, but do we see anything here about a tree? Okay, so struck by, wow, and I walked you through this exercise because I think some people get caught up because they're like, oh, I looked under struck by and I don't see what I'm looking for, so I guess it's not there, right? No, wrong. So a few weeks ago, I'm pretty sure that I gave you guys main terms that lead to V codes, and not V codes, Z codes, and I think I have an article on main terms that lead to the external cause codes. I'm going to have to find them while we're looking this up. Okay, well, let's continue because I wanted to be off of here within 11 or after an hour and 30 minutes. Okay, here's the article here. So I just uploaded main terms that lead to external causes. Okay, so struck by was not the way to go. So any other options? Hit, if you look for a hit, it tells you accidental to go to striking against or struck by. Well, we already went to struck. We didn't find anything. If you look at striking against, you see airbag, you see bottom, you see object, you see person, you see sports, you see wall. Still nothing there. So let's try accident. Let's see if we come up with something there. I just want to show you all the different words you can look up before I tell you the word to look up for here. So let's go to accident, and this is the last one we're going to look at before I tell you what the real word is. But I want to show you how long some of these terms can be and why it's important for you to practice now as opposed to on the day of a national exam. So accident. And I'll give you a few seconds since you're here, Jennifer, hanging out with me this morning. I know a lot of folks, I decided yesterday that I could not do this on Monday because I'm actually going to be spending some time with my family. And my family likes it when I can spend some time with them. So I decided to go ahead and do this morning for those of you who are listening by recording. So accident, as you're browsing through accident, you probably are like, wow, accident has a heavy focus on transport. I mean, and when I say heavy, if you look at the top of the page, accident, transport continued, transport continued, transport continued, over and over and over and over again. So do you see anything here about a tree? No. Okay. So download that list that I gave you. Download that list that I gave you. And let's identify another main term that we can use. And there's a whole lot of options that you have here. Activity, assault, assault by a tree. That makes me think of a cartoon, George of the Jungle. Okay, so let's see. Assault is not a good word because that, okay, Jennifer, forces of nature. So let's see, let's go over there. Forces of nature. Avalanche, blizzard, cataclysmic, cloudburst, cold, cyclone, dam, earth movement, flood, tidal wave. Nothing about a tree, huh? Okay, so looks like we're not going to be able to find anything related to specifically a tree, right? If you go to the term object, it just says falling from or in machinery, set in motion by, firearm, etc. So there's unfortunately a default that we can use. However, I want you to look for the word fall, falling, fall, falling. Because when the tree is striking you, more than likely, it's falling. Under, fall, or falling, look for tree. And it gives you a code. Now, oh, I want to mention something. You notice by tree, so main term, fall or falling, and go down to the end of that list, you should see tree W20.8. What you picked up, Jennifer, was always watch out for the subterms. Under the subterms, what you picked up was tree under fall from, off, or out of. And this patient didn't fall out of a tree. He was struck by the tree. So it was a falling tree at the very end of the fall words, W20.8. And remember, the words in parentheses are non-essential modifiers. So even though it says caused by lightning, you can just ignore that. That's a non-essential modifier. But let's look up W20.8. You see why I say I will always know who listens to the live lecture? Because they will either get lucky and find this code, or they'll have this code because they heard me say it. So W20.8 and W20.8 says other cause of strike by thrown, projected, or falling object. So it's kind of like a default code. And W20.8 says check 7th digit. So this is the initial encounter. So we know it's going to be a letter A. So what's our full code, Jennifer? So W20.8 XX and an A. And those X's, as an FYI, should be capital X's. So W20.8 XXA. Okay, let's hurry up because I want to be off of here in 7 minutes so I can shower. Okay, so the principal diagnosis is the traumatic fracture, because we know it wasn't caused by a disease process. The secondary diagnosis is that W20.8XXA code. Then this patient also had a procedure. And it says diagnostic arthroscopy of the left knee, application of a cylinder cast. Now, you guys should know that you don't code operations based on the discharge summary. You have to code an operation from an operative report. So there is an operative report for this case. It is typed, yay. And let me just tell you a couple of things. Number one, the cast application, we are not going to code that. That's going to be picked up by the charge master. Okay. In the operative report, the physician only documents a diagnostic arthroscopy. But in the pathology report, they talk about some synovial tissue via debridement. But the doctor didn't state that in the operative report. And so here is where we have a query for this week. We would query to determine if the operative report really needs to be updated, because I want you to think about it like this. If a surgeon was to get audited, they are going to request his operative note. And if his operative note doesn't show a synovectomy, we can only code the diagnostic arthroscopy. So you may recall from ICD-10 PCS, if they're just looking around, that's the root operation of inspection. So that's all you can code, because that's all we have documented. We would query. Now remember, when we query, the coding process is halted. What do I mean by that? The coding process is halted. That case goes on to a report called the DNFB, which is the discharge but not final build. Okay, one of two things is going to happen. Number one, the physician responds to the query. He updates his documentation, and we can code the surgical synovectomy. Or option two, we've queried the physician, he has not responded, we have to just code what he documented, which is the diagnostic arthroscopy. So for our purposes of this case, we are just going to say, we're going to code the diagnostic arthroscopy, which is inspection, and we're going to say that we would query. Because at the end of the day, if the provider does not respond to the query, we still want to get paid for the work that the hospital has done today. Okay, case number 19 is another record that is half typed, half handwritten. This is a young boy here, 4 years old, and comes in with a right testicular torsion, and then the discharge diagnoses, torsion right appendix of the testes. So here you'll notice that I mentioned that the admitting diagnoses and the principal diagnoses are not the same, and that is true because the admitting was a torsion of the testicle. The principal torsion of the appendix of the testicle, because now after study we have more specificity about the torsion of the testicles. Okay, let's see. This patient has 3 secondary diagnoses that were all present on admission. One is an endocrine condition in nature, something related to his fluids being depleted. Another one was about the fact that, and this chart is from 1985, the doctor says that he's mentally retarded. The coding manual does not use that terminology any longer. This is actually an intellectual disability, not mentally retarded. That is not a proper term to use for individuals that have intellectual disabilities. The documentation also mentions that this person is obese, and we are not going to list that as a secondary diagnosis. It's not impacting the treatment that was performed today. They don't do anything about the obesity. So when I mentioned that we're coding the floor and not the ceiling, we chose not to pick this up for this 4-year-old baby. Also, they mentioned urinary incontinence, and we're not going to code that either. Yes, the person is 4 years old, but they're not potty trained. Why are they not potty trained? Because they have the intellectual disability. So oftentimes patients that do have intellectual disabilities, they don't progress down the same path that a child without that intellectual disability would progress down. Okay, so the endocrine system disorder for the volume, the fluid depletion, we have a code for the intellectual disability. And then the third code is another condition that is from the genital urinary system in nature. You notice I'm giving you some tips, but I want to make you work for some of these codes. The patient has another condition that is from the genital urinary system, so I'll just give you a hint. It does start with an N. Let's see what else. On the H&P, the doctor mentioned something about the person on amoxicillin for an ear infection. But when you look at the medication administration record, they didn't give them any amoxicillin. So if you wanted to query, if you wanted to code that, you have to query the provider about it. So obviously we didn't code it. It would not impact the MSDRG because we didn't give them any medications for it. We didn't treat it. The doctor mentioned it. If you wanted to pick up a code for it, you would query, but we didn't pick it up as a code. Okay, and then the young man did have a procedure today, and it was exploration of the right testicle with excision of right testicular appendix. Now, remember our root operations. If they explore and then do something more definitive, remember, instead of coding it as an inspection procedure, we're going to code the more definitive procedure. And in this case, it would be the excision of the right testicular appendix. It wouldn't be a resection because they didn't take out the whole testes. They just took out the testicular appendix. Okay, so that was all for today. Thank you for hanging out with me, Jennifer. It's nothing like talking to yourself for an hour and a half. But I've gotten pretty good at talking to myself for an hour and a half, 2 hours. But it's always nice to have someone here live with me. So I will see you next week. And let's see, this is week 5. So we got week 6. Week 7, I'm going to do a review for the final exam. So definitely want to make sure that that you are there for that session. So enjoy the rest of your weekend and the Monday off. I know I'm going to enjoy my Monday off. Try to get some rest. All right, thank you so much. Oh, let me upload the slides. 1 second, I almost forgot. Okay, so here are the slides for today. And now I'm done. Thank you so much. Bye-bye.